Yeah, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove handy in your line of duty. So I welcome you all to part 97 of our pharmacotherapy MCQ series, majoring in basic oncology. Welcome. Our first question reads, apart from neutropenia, which of the following is considered a dose-limiting toxicity of paclitaxel? Is it ataxia, stomatitis, neuropathy, or PPE, palmar-plantar erythrodysesthesis? I'll give you 10 seconds to choose the correct answer. Neuropathy it is. Now, paclitaxel is a microtubule stabilizing agent which produces peripheral neuropathy as a major adverse event. Remember, paclitaxel binding to the microtubular polymer can lead to axonal degeneration, especially with larger doses greater than, for example, 200 milligrams per meter squared, or with cumulative exposure. Remember that. Let's move to the next question, please. And it reads, considering transplant preparative regimens in which cytarabine is administered, which of the following is the primary non-myeloablative dose-limiting toxicity seen or observed? Is it sinusoidal obstructive syndrome? Is it cardiotoxicity? Is it neurotoxicity? Or is it hemorrhagic cystitis? I'll give you 10 seconds to choose the correct answer. Neurotoxicity is the correct answer. Remember, cytarabine is well known to produce various neurotoxic events which include cerebellar ataxia and dysarthria. Now, hemorrhagic cystitis and cardiotoxicity are commonly seen with high-dose cyclophosphamide. That makes answer D wrong. Makes answer B wrong as well. Then sinusoidal obstructive syndrome is seen with agents like busulfan, so that makes answer A wrong as well. Let's move to the next question, please. And it reads, choose the correct statements among those listed below. Is it true to say that aprepitant inhibits warfarin metabolism via CYP2C9 and can lead to supratherapeutic INRs for patients on concomitant aprepitant and warfarin? Or is it true that both palonosetron and rolapitant have long half-lives and are thus more effective for preventing delayed nausea and vomiting? Or is it true that all NK1 antagonists such as fosaprepitant, aprepitant, netipitant, fosnetipitant, and rolapitant inhibits metabolism of dexamethasone, which leads to higher levels of dexamethasone when given concomitantly? Or is it true that dronabinol capsules have a higher bioavailability than dronabinol oral solution? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Both palonosetron and rolapitant have long half-lives and are thus more effective for preventing delayed nausea and vomiting. Now, both of them have long half-lives, around 40 hours in adults for palonosetron and around 7 days for oral rolapitant and 7.6 days for IV rolapitant. They have long half-lives indeed and are therefore recommended by the NCCN guidelines to prevent acute and delayed nausea and vomiting. Just like to emphasize that dronabinol oral solution has a higher bioavailability than dronabinol capsules. That is 2.1 milligrams of oral solution is equivalent to 2.5 milligrams of the capsules. So that makes answer D wrong. I would like to add that all NK1 antagonists such as fosaprepitant, aprepitant, nitipitant, and fosnitipitant, except for rolapitant, inhibit the metabolism of dexamethasone, which leads to higher levels of dexamethasone when given concomitantly. So that makes answer C wrong because of the rolapitant exception. Then I would like to add that aprepitant induces the metabolism of warfarin via CYP2C9 and may significantly reduce INRs, especially for patients on therapeutic warfarin. Now, the INR initially increases due to the first week's during the first week, and that warrants close monitoring. Then I would just like to add that each antiemetic agent has unique PK/PD properties that must be considered when selecting an appropriate antiemetic regimen for patients. Now, aprepitant also decreases the area under the curve of contraceptives. Patients should have alternative methods of contraception during aprepitant treatment and for 1 month after the last aprepitant dose if they are being managed for cancer and they want to avoid conception. Let's move to the next question, please. It reads, Mrs. JMW, a 51-year-old female CML patient, has been on imatinib for 1 year. Her disease has progressed to what we call blast face CML. The medical oncologist managing this patient has ordered BCR-ABL1 mutation panel and found her to be what we abbreviate as T315 small I mutation positive. So my question to you is, which of the CML agents listed below would be the best for Mrs. JMW at this time? Would you opt for omacetaxine, bosutinib, ponatinib, or dasatinib? I'll give you 10 seconds to choose the correct answer. So ponatinib would be the best option. It is indicated for T315 small I mutated CML regardless of the phase. It can be used in the chronic phase, accelerated phase, or the blast phase. Now, I'd just like to comment that neither dasatinib nor bosutinib is recommended in T315 15 small I mutation positive CML cases, since they aren't active against this type of CML. Now, omacetaxin can also be used for T3 15 small I mutated CML, as it isn't resistant to omacetaxin. It can be used, by the way, with limitations, in the chronic or accelerated phase, not in all the 3 phases, if they haven't failed 2 prior TKI agents. There's that caveat. It is an injectable CML agent that reduces protein levels of BCR-ALB and MCL1 independent direct BCR-ALB binding. Complex mechanism of action indeed. Let's move to the next question, please. And it reads, which of the tyrosine kinase inhibitors listed below is targeted towards BRAF mutation in melanoma patients? Is it vandetanib? Is it vemurafenib? Is it sorafenib? Or is it erlotinib? I'll give you 10 seconds to choose the correct answer. Vemurafenib it is. Now, vemurafenib, marketed as Zelboraf, is a tyrosine kinase inhibitor for the BRAF target. It is indicated in the treatment of metastatic or unresectable BRAF V600E mutation melanoma. I'd just like to add that sorafenib is active against BRAF. However, it isn't active in melanoma patients, so there is that limitation. Let's move to the next question, please. And it reads, Mr. W.A.J., a 63-year-old white British male patient, is initiated on tamoxifen by your medical oncologist for 5 years adjuvant therapy for his male breast cancer. As the specialist oncology clinical pharmacist in the oncology team, which of the following counseling points would you reinforce in this particular case while educating Mr. W.A.J.? Would you emphasize that he should be taking calcium and vitamin D supplements, since tamoxifen may increase the risk of osteoporosis? Or would you enforce the fact that tamoxifen should be used cautiously in those with hyperlipidemia? Or would you sensitize him to the fact that if he continues his international business flights, he needs to be aware of an increased risk of thrombosis from tamoxifen? Or would you remind him or prompt him that he may be at an increased risk of prostate cancer after tamoxifen initiation? I'll give you 10 seconds to choose the correct answer. I would prompt him that if he continues his international business flights, he needs to be aware of an increased risk of thrombosis due to the tamoxifen he takes. Remember, tamoxifen will increase Mr. W.A.J.'s risk of thrombosis. It is well known that tamoxifen possesses anti-estrogen effects on certain tissues, which include the breast, vaginal mucosa, and it also possesses estrogenic effects on bones, on lipids, and the endometrium. Now, tamoxifen has also been associated with hypolipidemic effects, and it also carries similar thrombotic risks as other hormonal agents, that is the estrogen oral contraceptives, and patients should therefore be made aware of these adverse effects. Let's move to the next question, please. And it reads, basing on prescribing information on product inserts, which of the medications listed below should be taken with meals? Is it hydroxyurea? Is it Zeloda? Is it Elotinib? Or is it Lapatinib? I'll give you 10 seconds to choose the correct answer. Capecitabine or Zeloda it is. Now, this particular product should be administered within 30 minutes after a meal. I'd just like to add that Lapatinib, which is Ticab, and Elotinib, which is Tarceva, should be taken on an empty stomach, but it's written in literature that their absorption is significantly enhanced when they are taken with food, and that may lead to abnormally high serum levels. And I would like to emphasize that there is no recommendation for hydroxyurea in its prescribing information, so you can take it without regard to meals. Let's move to the next slide, please. And the question reads, Mr. JKL, a 46-year-old male patient with confirmed non-Hodgkin's lymphoma, is scheduled to receive his first cycle of SHOP chemotherapy by your medical oncologist. He informs his medical oncologist that he doesn't like taking oral tablets or capsules, but prefers liquids or any other drug forms. So my question to you is, which of the 5-HT3 antiemetic regimens listed below would suit JKL the most? Would it be dolancetron 100 milligrams orally before SHOP, or would it be 8 milligrams of oral ondansetron disintegrating tablets before SHOP, or would it be 8 milligrams of ondansetron IV stat, or would it be transdermal patches of granisetron applied the day before SHOP and left in situ for up to 7 days? I'll give you 10 seconds to choose the correct answer. So C would be the best bet. So I would opt to administer 8 milligrams of ondansetron IV stat. Remember, oral ondansetron is recommended at a dose of 24 milligrams daily versus 8 milligrams IV daily. So that would make answer B totally wrong. Now, dolancetron, marketed as Anzemet, would be appropriate, but we were told very clearly the patient didn't want any oral medication. So that makes alternative A wrong as well. Then I would just like to emphasize that the transdermal patches of granisetron, marketed as Sancuso, make an attractive option, but it isn't appropriate in this particular case. Now, the cost difference between the two agents favors ondansetron IV stat versus the patches. Now, even though the patches may last 7 days, the data available for patients actually benefiting from prolonged granisetron usage is lacking in those receiving chemotherapy on a single day. I'd just like to add that data with single or daily oral granisetron demonstrates lack of efficacy in delayed emesis prevention. And I would just like to remind you that this patch may have a role in the prevention of acute emesis in multiple day chemotherapy regimens, not in single day regimens. However, in my opinion, on a certain single daily dose, that is the 8 milligrams IV start, would be the most frugal way to approach this challenge facing Mr. JKL now. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up and to like it and to share it widely with your peers. I'd also like to urge you to leave your comments at the bottom of the video, and if you haven't yet done so, I would like to urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. I thank you very much for viewing this video and for listening to me, and I sincerely appreciate your partnership and your continued support and very kind collaboration, and I look forward to interacting with you in subsequent videos. Thank you very much.